So we're gonna go in project order. So the first is we'll allow an opportunity for some of our B1 projects, as Tyler so well passed the test of explaining, to share.
Yeah, the pressure's on. Usually when I get a mic in front of me, it doesn't go well. Again, the description of the B1 is the social determinants of health, the comprehensive core screening assessment, and then the integration or collaboration between primary care and community-based mental health. Sue Ellen has a couple statements from our care team coordinator, Michelle, who's not here today, so she'll be able to speak to the West Central side of things. What we've seen at primary care is that the population of patients that are within the program are not always the best at following up. So what we found is there's a certain amount of compliance that occurs or non-compliance that occurs in terms of follow-up either in that community-based mental health setting or in the primary care setting. So that collaboration between the two groups saying, hey, they didn't show up for us, did they show up for you, or vice versa, has been very important because each team can send the same message to the patient to make sure that they're following up appropriately. So from the medical standpoint, what has been really helpful for our team is that the services that are available at the community-based mental health in terms of the encompassing care allows for a lot of touch points with those patients that I don't necessarily get to see them as much as they do. So hearing how they're doing in terms of progression and arriving kind of in a crisis versus how they're presenting to the community-based mental health is important to hear because we've had some really good success. People are either more secure in their housing or more stable in terms of their mood. And once the housing and mood become more stabilized, then they're able to get the full mouth dental rehab that they need or to show up to their job more consistently. So I've really appreciated West Central's information in terms of follow-up because it's 2 to 3 months between appointments at our end sometimes, and getting kind of the word on the street is really important from West Central. So the patient's priorities from a medical standpoint are not necessarily those community-based mental health priorities, but if both of us can see what those are, then those needs can be better met. Any specific questions before I pass on the...
How do you communicate that?
So what we have is we have a care team coordinator which facilitates a multidisciplinary meeting which is once a month. So our care team coordinator maintains the shared care plan, which is a standalone electronic document that both teams can have access to. But the care team coordinator's job is basically to make sure that shared care plan is up to date. That's the same shared care plan that shoots out on the printer in the emergency department if the patient presents to the emergency department for another complaint. And Mark can kind of go into that technology a little bit. So between maintaining the shared care plan and facilitating those multidisciplinary meetings, and those have either been in person, shared between Dartmouth Primary Care or West Central and Lebanon, or they've been WebEx.
Good morning. So I have a real life story, and this is not made up, which is really an important piece. It's a true story. So let me just tell you about a particular patient that is on this interdisciplinary team, and the patient is shared between West Central Behavioral Health and the primary care program at Heater Road and at Dartmouth Hitchcock. So this patient is a 53-year-old single male who was self-referred to WCBH in January of 2018 for the first time. So it was a long time of not receiving mental health services. His diagnosis is major depression and alcohol dependence in remission. He's homeless, couch surfing, and was living outdoors. He was followed then and continues to be followed at Heater Road Primary Care with Dr. Voigt. He had one previous hospitalization in September of 2017, but didn't follow up with any of the aftercare treatment. He had received some mental health treatment over the years, over his 53 years, but primarily it was only medication, and states that he really never took it consistently. He used alcohol heavily, daily actually, until 10 years ago. He had a DUI, his license was revoked, and served time in jail as a result of his drinking. He had some periods of extended sobriety that was motivated due to health concerns related to open heart surgery for a congenital birth defect. He has a pericardial tissue heart valve replacement and several mild heart attacks. He maintained his sobriety until June of 2018, when he relapsed briefly and was arrested for another DUI and reports abstinence since. So that's sort of the background of this person. It's pretty complex. When you think about social determinants of health, there are a lot of issues sitting in that particular story. So here's what happened to this gentleman as he became more involved in this relationship. So this gentleman was involved in the interdisciplinary relationship between Heater Road and West Central, beginning in March of 2018. He was also not engaging in regular MD appointments and needed support to get his medication into compliance. So he wasn't going over to his Heater Road primary care appointments, and he wasn't regularly attending West Central Behavioral Health. His anxiety about health was a major obstacle in addressing chronic health issues. Additionally, he struggled with memory challenges and social needs that overshadowed his ability to address health and mental health concerns independently. The client was offered ACT services at WCBH, which is assertive community treatment, which means we go out into the community to the person's living, chasing this guy down, he was homeless, but going out into the community to reach out to these people that can't always come into our agency for services. His case manager meets with him several times weekly and provides support and reminder and tools to help the client to meet his obligations. So the mental health section of this shared treatment plan consists of attain stable housing, develop awareness of anxiety and health and coping skills along with managing mood changes and increase concentration, maintain employment. And the client has a long-term goal of having his license returned related to his DUI. His license, as I said, was revoked. He's trying to get his license back over time. So this is how the collaborative treatment has helped. Progress to date. Client has obtained housing through Twin Pines Housing at Parkhurst, which is the new housing development, if you don't know it, right in downtown Lebanon. So he lives there now. He has obtained full dentures. You heard Dr. Voigt talk about sometimes people really need dental care as a big part of their recovery, and it really makes them less self-conscious when they're thinking about getting employment and other things that they might do. Full dentures. He's up to date with all medical appointments, so he's actually attending all of his medical appointments regularly. He's maintained stable employment at the Lebanon Senior Center. He continues to engage with Headrest, which is, as most of you know, is the substance use counseling center in Lebanon, counseling 2 times weekly and has maintained sobriety. And he continues to engage in weekly AA meetings 4 to 5 times a week. So if you don't think that's a success, that's the best story. So real life story, not made up just because we talked about social determinants of health. So thank you.
Thank you, Swell and Tyler. Now I'll invite up Kelly Murphy from the Valley Regional Hospital B1 project.
To share Valley's project, the information around Valley's project, I want to share with you an email that was written yesterday to the senior team, updating them on the progress, specifically with a patient story. And so I'm going to be leaning on this and reading from this. For all the IDN projects, it is easy at times to feel overwhelmed and inundated with project logistics and requirements of the grant funding. I've heard a few comments that it's a waste of time and money and won't produce any valuable results. From my observations as a project manager for Valley Regional Healthcare's B1 initiative, I would argue to the contrary. Last week, the team at Valley Primary Care walked through a patient care situation that elevates and highlights why this project is critical for both patients and the delivery care model. A 20-year-old single male made an appointment to address a chronic medical condition with his PCP, and he brought his dad with him. He was given the CCA patient questionnaire, which is something Valley Regional Hospital's patients have never received prior to the B1 project. The GAD2 and PHQ-3 screening components within the questionnaire were positive, and a complete GAD7 and PHQ-9 were given. In all paper documents, the patient denied thoughts of suicide, and when he met with his doctor, he didn't disclose any thoughts of suicide. But the B1 team created a procedure that requires a social worker to be called in to give a psychosocial assessment when receiving positives on this patient questionnaire, thereby giving an additional opportunity for this patient to have a more in-depth discussion. Through quickly building rapport, the social worker was able to extract his experiences with depression, including his symptoms and length of time that he has felt depressed, and observed that she should revisit the question of suicide. The patient disclosed he was in fact having thoughts of suicide and had a plan, as well as a backup plan. The medical provider was consulted and asked to return to the room for safety planning. The patient, the provider, and the social worker together created a safety plan, and the son asked his dad to come into the room for part of this planning process. He started on a medication to address insomnia and his depression, and a connection was established with a mental health provider for therapy. A week later, he was less flat in his affect. His suicidal thoughts were fleeting, and he did not include any plans to end his life. He is now able to envision future steps in his health care, where at the first meeting, his focus was basic survival. It is a simple process to place a monetary value on the time and hard costs involved in this B1 healthcare transformation. But let's note the parts that aren't so easy to calculate. Number one, if this had occurred prior to the B1 project, this patient's mental health condition may not have surfaced at all while the chronic medical condition was being addressed with the provider. There was no CCSA to identify any positive social determinants or mental health status. There was no shift in perspective from stick to the chief complaint, asking opens up too many unknowns, to recognizing now sometimes what's going on around you can impact what's going on inside you. So we ask, what is going on? Number two, paper is not 100% the answer. Without the social worker providing the additional human interaction to assess and assist, this patient may have walked out of the practice with his plans to end his life securely in place. Remember, he initially denied all answers on the paper form. This social worker position has proven to be a tremendous asset and impact for the practice, especially as the initiative gets rolled out to all providers and all practices. And the team will soon welcome a community health navigator whose role will be to directly assist the patients in bringing the gaps of social determinants such as transportation and housing, which were identified in the patient's meeting with the social worker. Number three, the procedures identified in the months of planning and preparation worked. The pathways created for the patient and social worker to follow when a positive CCSA was identified worked. And number four, without the social worker providing intervention, the medical provider would have lost, postponed, and/or canceled approximately 3 hours of scheduled patient care sitting in the waiting area while navigating this crisis. Instead, she was able to confidently carry on with caring for other patients, knowing that the social worker was caring for the patient in crisis, and join the conversations and planning when needed. That in itself saved the healthcare system from lost revenue, a backlog of disgruntled patients who would have been delayed or rescheduled, and staff stress. As the healthcare system, Medicaid, and third-party payers observe and analyze the impact of the integration delivery network, it will be imperative that stories like this also be integrated into the equation of cost-benefit. This team has spent the past year mapping their workflows, creating new procedures, designing patient questionnaires, carefully weighing options and choices, training, and learning new ways of delivering health care. For this one particular patient, he walked out of the PCP's office in a far better state than when he entered, thanks to the team that drives the B1 integration pilot. Thank you.
Thank you so much, Kelly. And I just wanted to let everyone know the social worker that we were referencing is sitting right over there, Krista. So I just wanted to say thank you as well, Krista. And to all of you who are doing the same work as Krista day in, day out. It really makes this worthwhile. So those are the two B1 projects that we had set to present today. I wanted to make sure that we give notice to our other B1 projects who are in the room, who are sort of just getting started. The B1 project at Alice Peck Day, the B1 project at Newport Health Center, the B1 project at Monadnock Community Hospital, the B1 project at the Dartmouth Hitchcock General Internal Medicine. We look forward to all of the progress in the next year. So with that, I want to invite up Glenn Lawrence from Monadnock Family Services, representing on behalf of the co-pilot project, which is a blend of our care transitions and enhanced care coordination projects. Thanks.
Good morning. I'll provide a brief overview of what the co-pilot program is and what it represents. So the co-pilot program is a joint venture between the Monadnock Collaborative, that would be Monadnock Family Services, Cheshire Medical Center, and Service Link. And the design of the program, I think, was timely and very focused on some very specific needs that we saw that needed to be addressed within the community, and those are threefold. This project was aimed to service folks with psychological and emotional difficulties, and chronic mental health and health challenges. So the need that we identified was that by combining the resources of Cheshire Medical, Service Link, and Monadnock Family Services, we've really pulled together three entities with specific expertise and forces to bear. So Monadnock Family Services, I think, brought the psychological skill set, expertise, and the clinical programming that was necessary to address the psychological needs of this particular population. Service Link really brought expertise related to what are the services out there, what are the services that we need to link people up with so that they can have a successful intervention from our services, and that was really crucial. And having Service Link on board with us gave us a range of supports and expertise that, frankly, Monadnock Family Services just didn't have. Everything from complex eligibility difficulties, getting home care services in. So it was a really important link. And then with Cheshire Medical, as sort of the main point of referral for the clients in our services. So it's a really kind of dynamic program, and we're really excited to have this program up and running. So there are so many client success stories and examples that it was hard to pull a particular one, but I think I'll do that, and I think the person that I represent will be emblematic of the service linkages and the great work that I think is being done here. So there was a guy that came to the program, and he somehow, he was living in Alabama, and he jumped on a bus and came to Keene, because he had heard that New Hampshire might be a pretty good place to live. And he had no resources, no family supports, no connections, and really no plan other than he thought he would come north. And he came last year in the just at the start of winter, homeless, living in a tent, wandering the streets, and drinking. And he came to our attention because he was repeatedly going to the emergency room at Cheshire Medical largely due to seizures. So he was referred to us through CTI. So there are two streams within co-pilot: critical time intervention and enhanced care coordination. And our critical time intervention program really is trying to pull people from the hospital in particular. So when we met this with this gentleman, the revolving door would be he would have a series of seizures. He would be prescribed seizure medication. They would get him back on track with some other medications for some other health problems that he had, and he would be out the door. And 5 days later, he is back at the emergency room. No resources to fill his medications, or would forget them, or from moving from tent to tent within the woods, they'd sort of be gone. He would drink again, and he would have seizures. So when we met with him, he drank, his report would be about 2 6-packs of beer a day, and he did not see that as a problem in his particular life. But when we talked to him about the connection between his seizure disorder and his drinking, that seemed to be sort of the first spark of some understanding that he should be thinking about whether this is really a sort of a problem in his life. And we were able to actually get him into one of our Phoenix House, a program that we work fairly closely with. And he had a very successful stay there, a 28-day stay where he came out, and was seizure-free for a month, and then he was back at the emergency room, and had another sudden series of seizures. I bring that up because for him, I don't think we're at sobriety. I think we are at contemplation and change, so to speak, but he's making real progress. And the things that are very different now than when he came to us is that he had, when he came in from Alabama, he hadn't seen a doctor in 15 or 20 years, had not been to the dentist. He had he'd had a knee injury from many, many years ago that was both poorly treated, and he had chronic difficulties with that. Today, he is he has a place to live. He's connected to church. He's developing friendships in the community, and he's doing really well. He is not where he absolutely needs to be, but he is on that road to recovery. And I think it was very heartwarming to work with someone who was living in the woods a year ago before this project began, and now has a roof over his head, 3 square meals. And he is recognizing for the first time in his life that alcohol is an issue and something that he wants to work on over time. And that's going to be a work in progress. We just got him into seeing a substance abuse counselor, and that took months. Because while he was willing to entertain the idea that maybe I shouldn't drink so that I don't have seizures, the idea that he actually had a problem with alcohol was not foremost in his mind. But we are at the point now where he's actually going in to counseling on a regular basis and recognizing that this is something that can really improve his life tremendously. I had asked one of the co-pilot care coordinators to actually tell this story because they're so much more powerful when the person working with the individuals in the room and describing these services, and they weren't able to be here today. But so my shout out is to the coordinators and the team that actually is on the ground working with people. Thank you. Does anyone have any questions for me? Okay. Well, thank you very much.
Thank Thank you, Glenn, and to the co-pilot team. And then I'll invite up Terry from the Intensive Substance Use Disorder Project.
Good morning. My name is Terry LaRocque, and I'm the clinical director at Dartmouth-Hitchcock's Moms in Recovery program. Our program, for those of you who are not familiar with it, is about 5 years old, a little bit more than that, and started as an outpatient program, integrated care program for pregnant moms. Is now a program that I can tell you a little bit about that is for pregnant and parenting moms. Until last year, it was a year ago this week, because of IDN funding, we were able to bring on board additional staff and open our first intensive outpatient program. So the moms who we've been caring for 4 years who needed a higher level of care in our program, we were sending them other places. And this has given us the opportunity to let them stay with us if they desire and receive 9 hours a week of intensive outpatient care. We've been able to hire another clinician as well as a case manager. And that has been unbelievable for our entire program. So I would say that the funding has benefited women in our program at all levels, including in our outpatient care. The women in our IOP, so that's intensive outpatient program, we started in February, the beginning of February last year. We had our first patient come in April. We imagined that we would have this waiting line of people and they would be beating our door down. And in fact, what happened is we had to go out and knock on doors and, speak to child protection and speak to probation and parole, speak to drug court and say, hey, we have this program. Would you like to come and check us out, talk to your patients about it? We're open for business. It took us a little while to get up and running. Once we got up and running, we realized, whoa, we needed to slow down. We needed to stop and hit the reset button, because patients who were coming into our program actually needed residential level of care. And it was really apparent very, very early on. So because of the extra clinician, because of the case manager, because of our recovery coach, because of these additional services, we were able to do that, pull patients out and bring them to an individual level of care, being able to offer them integrated treatment with MAT and OBGYN care and all the other things that we had, but they weren't group appropriate yet. So we were able to work with them individually to determine whether they needed residential care or to just sort of settle in to see if they could get stopped and then become part of our IOP. So what started as an IOP project has turned into a project that's also offering individual care before IOP and is when people finish IOP, they're able to now, we've created this step-down phase, so they're receiving care twice a week before they drop again down to once a week. So that's sort of the structure, and that's what we've been doing for the last year. I was really interested in listening to the SDOH conversation, because one of the things we've learned in the last year, and in our outpatient program in general, our case manager, who's been able to do SDOH evaluations on every patient as soon as they come in, we're looking at those results 5 months, 6 months, a year later, and they're wrong. Women are coming in and giving us information that's actually, they're far underreporting the severity of their living situation and of the danger that they're actually living in, the resource insecurity. The relationships that our women have been establishing with our case manager and with the clinicians, a year later, we're starting to peel apart some of the real complexities of their life. And I think our SDOH data is grossly inaccurate. We need to really go back and look at that. I'm thinking of a couple of women who, women in our program are coming in and their biggest goal, in addition to recovery, or maybe more than recovery, is to maintain or regain custody of their children. They are scared to death to come in and tell us how bad things really are. It takes a lot of time, it takes a lot of relationship building, a lot of trust, and mutual respect coming from our team before patients will start to share the details of how bad things really are. And so what we're finding is that, especially in the last year, with regular meetings with our case manager, regular meetings with their clinician that we can now provide, we're finding a little bit more out about their legal situation. That in fact, they do have serious housing insecurity, that their partner is really struggling with substance misuse, and that they're in an intimate partner violent relationship. But those are the factors that really concern them, are going to become part of child protection assessment. And if they come through the door and share all this information at the beginning, then their goal of having their child and maintaining custody is not going to be, it's not going to happen. So that's been something that's been really, really helpful to be able to do that. I was thinking about a patient. We are not all rainbows and unicorns. We have patients who we don't know where they are. They have come and gone, and we've lost them to care, and we've had patient success stories. One patient in particular, I was just thinking about. We've seen quite an increase in the last year, definitely the 2 years, and definitely in the last year of polysubstance use. We're seeing a lot of stimulant use. We're seeing a lot of methamphetamine and a lot of bath salts. This patient who came into our IOP a few months ago was the very first patient who I had done an eval on, who said, I don't have any other addiction history except bath salts, and I want to stop using bath salts. And so, we started as an opiate use, disorder sort of focused program, and we're seeing more and more of this. But this was the first patient who said, I'm here for bath salts, help me out, please. And she has just completed 24 consecutive sessions of IOP, did not miss one, was in amazing communication with us, and very solidly transitioned to coming to us twice a week. And as she was transitioning down out of IOP, and she's working to regain custody of her children, her partner's incarcerated, and she's living in transitional housing right now. So she has lots of goals, and one of them is housing, employment, and reestablishing her children in her care. So she's stepped out of IOP. She's down an outpatient level of care. We did a care plan with her and looked at treatment goals. And I said, why don't you think about, you might want to consider, getting a job. That was one of her goals, so she could have better housing. And, you have time, maybe a little too much time on your hand right now. How about taking a class or something? She came in. In the last 2 weeks, she's found 2 jobs and started working in 2 jobs. And she came in yesterday, and she shared that she had just been on the phone with the admissions director at SNHU, and she was going to enroll in 2 different classes. So it was really encouraging and exciting. She's going in a really great direction right now, and we'll see. We'll continue with her 2 days a week, and then she'll drop down to once a week. But the idea and funding, the work that she's done with the case manager around her housing, the work that she's doing around education right now, we wouldn't be able to do it without this. Any questions? Okay, thanks.
Great. Well, thank you so much to all of our projects. We do have one more project that's not represented here today, the Enhanced Care Coordination Project that operates in Sullivan County. I know many of the partners who sit at that complex care team table are here today. That group has been meeting monthly for the better part of a year to kind of root down into the community and to community support partnerships in Sullivan County to work on what is complex care case management in Sullivan County, what's needed, how to share information, how best to make care coordination, who to determine who's leading in care for some of the most complex families and individuals. The project is really moving along. They're set to meet with Lucy Hodder, who's UNH Director of Law, next week to talk about what is multi-party consent, how feasible is that, what are opportunities to think about case sharing on a broader scope, and they are an incredible group, and so we're happy to have them on board as well. So thank you all to all of our projects, and now I'm going to re-invite Ann up to introduce the workforce updates. Thank you.
Before we move into just a broad panel discussion of all of our projects and give you a chance to dig into not just the patient stories, but successes, challenges, processes, and for those projects that are just launching or in incipient stages, to have them have a chance to walk you through some of the stuff they're doing, we've also wanted to draw attention to some of the impact stories of our workforce funding. As you all know, many of you have applied for our requests for awards for either recruitment, retention, supervision dollars, or community supports, or peer recovery. And that's a big part of what we're doing too, with expanding the capacity of the workforce and really trying to support our organizations and being able to handle and take care of all the patients and handle the referrals and all of that that's coming about from this great work in the project team. So with that, I have a few partners who have offered to share their stories of the impact from the workforce funds. If you haven't offered and would like to also, you're welcome to come up to the podium. But first, I'd like to introduce Cameron Ford and Matthew. Cameron Ford, the Executive Director of Headrest, who has some of our community support funds for vocational employment training in a partnership with Hypertherm, as many of you know, is a large organization up in the Upper Valley. And he's brought today Matthew McKenney from Hypertherm to share their story about how they're helping those in recovery secure employment and the importance of that. So.
Thank you, Ann, and thank you, everyone. We were excited to receive funding from the IDN to help us hire a vocational specialist and start a new project with Headrest. It was actually